May I now invite the next panel to join, and Dr. Aradhna Rathod is the moderator. This session is going to tell about the walking onto foot and ankle in low GOP population. How do you resolve the issues? Over to you, Aradhna.
Yeah, thank you, sir. Thank you so much. Can I share my slide to introduce the speaker, sir?
Go ahead, please.
Yes, sir. I hope my screen is visible.
Yeah.
Yes.
Okay. Yeah. So the first speaker is Dr. Rajiv Vohra, sir. Already has been introduced in the previous session. Sir is consultant foot and ankle surgeon in Amritsar, and he was past president of IFAS. And sir is known for his academics. He's associate editor of various journals and editor-in-chief of various journals. Second speaker is Dr. Gurunath Wachche, sir. He, sir, is associate professor in orthopaedics at VM Government Medical College, Solapur. Sir is known for lot of work. We call it as Jugad for most of his cases. Third speaker is Dr. Ankit Khurana. He is associate professor in Baba Saheb Ambedkar Medical College and Hospital. He is a very dynamic foot and ankle surgeon known for his academic contributions like publications and being author in various chapters. Last speaker is Dr. Savithri. She is assistant professor in Gandhi Medical College. She is a very dynamic young foot and ankle surgeon of our country. So over to you, Rajiv Vohra, sir, for presentation.
Okay. I'll just share my slides.
Yes, sir.
Can you just share it? Can you see my slides, please?
Yes, sir.
Okay. So we are talking about, low-income populations and how we innovate to these populations. So in certain scenarios. So the scenario which I have chosen today is the tumors around the foot and ankle. I know these are very rare sort of tumors, and not many surgeons are going to see these tumors, and the reconstruction is really, really challenging in these cases. And this is one of the reviews where they just saw out of 73 cases, the most common type of the tumor was a giant cell tumor, and this has been our experience also at our center, and somehow we saw a few cases of a giant cell tumor in our institute. I know when it's come to the surgical treatment, the most of it is curettage or extended curettage, but these curettage you can manage with your grafts most of the time and the cheap implants which are available. But the real challenge lies when you do the resection. I know in the Western world there are a lot of options. You have endoprostheses, and they come in different shapes and sizes. Then they have an access to the allografts and PMPs and you name it, and you BMAC, everything on the table. But unfortunately, in our lower group income population, neither they can afford it, nor we have the availability. We don't have. Now we do have these sort of implants a little cheaper, but in low income group, they can't even afford an implant like this or implant like this. So then we have to innovate and treat these patients. And I'm going to take you through certain cases where we have adapted to the resources, to our resources, and we have tried to cross these barriers, how to salvage those patients. All so look, this is a 31-year-old male and a giant cell tumor. And when we first saw this patient, we asked this patient to come for biopsy and do, but unfortunately, due to money, he again left and came 2 months later with this sort of tumor. Now the challenge was how to do it after this resection. So what we did, we just did a lower radius and a simple plate. If you see here, the combination of these plates, we took the graft from here, then reversed it and autogenous graft, and what we got was this. So the patient with this incision, just using our resources, we could go get this function to the patient, and now the patient is almost 2.5 year old post-operative, which he doesn't have any recurrence as well as any problem or any implant failure or something like that. Okay, this is another patient. She was treated somewhere else. You see, there is a recurrence here. She presented with a pain, recurrence of the smelling here, and the limitations of the movements. And then what we did again here, this was the MRI of this patient. You see whole bone cement void here on the MRI. And then again, we used the two plates. And what we did was, this is the plate, and we made a slot here into the talus and just fit it into the talus apart from this. And again, the fibula from this side was taken and autogenous graft was taken. All these implants just costed 5,000 rupees, and autogenous graft the same. And let me show the result which we could get. And we have been following this patient for around about 3 years, and she's doing perfectly fine. There's no recurrence in that. This is another case. I know 3D printing and people would go for talus replacements in these cases, but the keeping in view again the pocket of the patient, they were not interested at all, putting some money into it. And this is a simple, again, a combination of the nail and the plate. And look at the graft which we have, chosen for this. The combination of we took a tricortical graft as well as the cancellous graft, and then the fibula from this side, and we just could get this sort of construct. And you see here, this is after the 6 to 7 months that the patient himself is walking. So with matched ourselves to our resources, and we could give this function to the patient. This is another patient. It was done somewhere else, and someone had put the bone cement there in the navicular for a giant cell tumor, and the patient had a recurrence here. So it was a real challenge. And then we did the whole of the excision, and this was again a tricortical graft was taken and just stabilized. Unfortunately, this patient developed this sort of complication. He was going second surgery. So what we did was we did a flap in this patient, and ultimately the patient went on to heal. And this is what this latest status is. And we have again followed this patient for 1 year, and this patient is just doing fine without any recurrence, without any breakage of the implant. So let me take you. This is another interesting case. Again, a navicular tumor, and it was again turned out to be GCT, and you can see how these patients are presented to us. Again, it was a challenge to reconstruct with this, and we had to excise everything. Again, a combination of the graft and a simple, foot plate was used to get this. And this patient again had a bit of during just after the COVID, he had infection in this region, and then we had to remove this implant. You see, he developed the exposure, and finally, even after the removal of the implant, everything went on to heal, and the patient is walking. So you see, even a low income can be a barrier to the treatment of foot and ankle tumors, but you have to do the adjustments according to your resources, and which you can really face these challenges. And we don't have allografts and the big endoprosthesis or 3D reconstructions, BMPs, and all that. And we have an autographs. And fortunately, when we talk about the low income group, they don't mind giving these autographs. They allow you to take these incisions to procure the autograph from your body at the different sites. So maybe we are blessed with this, so we can face across these barriers of reconstruction in our low income group with the resources which are available to us. Thank you so much, Aradhna, for giving me the opportunity. And once again, thank you to the town, this virtual meet for giving me an opportunity. And I will be happy to answer any questions. Thank you so much.
Thank you, sir. Sir, we can take the questions in the end after all our presentations are over. We will move on to the next speaker, Gurunath, sir. If you can share your screen. Gurunath, sir, unmute yourself.
Yeah.
Yes, sir.
Can you hear me?
Yes, sir, we can hear you, but we can't see your screen. Till sir probably starts with his slide, we can take few questions. Vohra, sir, did you have any kind of infection in your cases, sir?
I showed, a few cases
Yes,
where
sir.
we had infection. We had a wound complication in one
Yeah.
particular in the midfoot. You see, and there was another one immediately after the COVID. He went into fever, and after the fever, he developed the sinus into the navicular, and then we had to remove the implant. But as far as the outcomes in those patients, there wasn't much of a problem. All the infections ultimately subsided. Mainly the infections were where the soft tissue cover was involved.
Got it, sir. No late infections, right?
No late infection. We have followed these patients. They are going fine till now.
Okay. Yes, sir. Yes, sir.
Can you see my slides?
No, sir. We can't see your screen.
Because I have clicked the start sharing. I can't see anything here.
So your slides are visible. I think you stopped sharing now. They were visible like a couple of minutes ago.
Yeah.
Okay. Choose what to share to the message is there.
Choose full
screen. Or
entire screen or full screen.
Okay, entire screen, right?
Yes, sir. Yes, sir.
Okay. So now I can see the screen here, but I can't see my presentation here. I have already opened it.
No, have you shared your presentation? There's something. There's a column which says share. Share your. You have to click that
Entire
button.
screen.
Now,
Yes. Now we can see, sir. Now we can see. Yeah.
Open your presentation, please.
Yes, sir. We can see.
Full screen.
Okay. Can you see?
Yes, sir.
Perfect.
Okay, thank you very much. Very good morning to all of you. I just want to share a simple KY technique for treating the intra-articular fracture by transarticular method. So as a foot and ankle surgeons in last 12 years, I have done fellowship at Alabama, USA under Dr. Ashish Shah. Thanks to my national mentors, Dr. Rajiv Shah sir, Dhillon sir, and Dr. Sampath Dumbre Patil. I basically work in private and government setup where I do get lot of foot and ankle trauma cases, fresh cases, neglected cases, and revision cases. So this is how we get the complex trauma cases and compound fractures and various neglected, and I do get a lot of revision cases also, because the foot and ankle department is now gaining a popularity in our area, being a rural area. So what are the important hurdles as a foot and ankle surgeon being working in the government setup? There is large waiting list of polytrauma cases due to less manpower and limited resources, non-affordable patients, priority for long bones is always there, and the patient do get late presentation due to their ignorance, and they have got more pain tolerance in rural part of the India. And there is also poor post op compliance from patient side, and they cannot get admitted for long time. This is the scenario here. So this is the scenario in government setup, you can see here. So what we do at our setup to overcome these barriers, this is very important as working at the peripheral setup. So last 10 years we started using a simple K wire for transfixing intraarticular calcaneal fractures. We do get a lot of calcaneal fractures, fresh fractures, isolated, comminuted, complex fractures. So we have done a multi-centric study at Pune with Dr. Sampath Dumbre Patil and Dr. With our government medical college and private setup. We have published a large series of 220 cases 3 years back. So we know as calcaneus is very common tarsal bone fracture. Variety of treatment options are there. In spite of doing best treatment, we get many complex complications due to the technical procedures, hardware. So it is very important. Less is more in. It is very true in calcaneal fractures. So you can see various modalities with various approaches and fixation methods. So this is the paper we published in 2020. A simple surgical technique of transarticular K-wire fixation through sinus tarsi approach for treating intraarticular calcaneal fractures, mainly Sanders type 2 to 3 and in many of the type 4 cases. So what we do is we do a sinus tarsi incision, as we all know. Then we pass one K-wire from lateral to medial side in the inferior sweep run and cell height of the calcaneus. Then very important is we identify the facet and visualize the posterior facet with the help of this non-traumatic homogeneous facet. Then you part from the of the calcaneus through the lateral facet of the calcaneus into the talus. This is very important wire. And the second K wire from the medial aspect with to fix the inferior tuberosity into the talus. So these two K wires are passed after reduction of the posterior facet of the talus and the calcaneus. Here you can very well see that the reduction is there. And this is the K wire which is passed from the calcaneus into the talus as a transfixed manner. Whenever there is, you get the anterior facet fracture, you can pass the additional K wire from here. And then most important is when you need, you can pass the calcar screw, that is the sustained screw, and it is passed from the lateral to the medial side, posterior to the anterior side, and caudal to the cephalite direction. So this is very important. And this is how we pass in the axial position only. We pass under the Siam guidance. You get both the wires in epilateral and Brodon's view to see the exact position of the two K wires, transfixing K wires, and your sustained screw. So this is how the post-op picture looks. Only two K wires with the reduction of the posterior facet in position and the sustained canal screw. Post-op X-ray, you can see here the two K wires from the plantar aspect, and this is the post-op CT. You can see the reduction, and there is no varus valgus, and the calcaneus height and the pitch is maintained here. So how you pass the wires? The number of K wires depend on the fracture geometry. This is very important. And the K wires are introduced from the plantar aspect, and they are kept outside to avoid the irritation in lying down position. And these K wire help to maintain the joint congruity, axial alignment, height, width, and the length of the calcaneus. Additional K wire, additional S sustentaculum screw can be passed from the lateral to medial side. So this is the case of pediatric fracture. You can see this is managed only with the 2 K wires. You can see here the good reduction, stable reduction here. This is the pre and post-op X-ray. 3 months follow-up you can see after the removal of the K wire, and this is 2 years follow-up. These are the clinical photographs. You can see there is no any swelling, no deformity. So this is the case, Sanders type 3, 55 years old patient. You can see the post-op with the only K wires and the calca screw here. And this is after removal of the K wires. These are the follow-up after 4 months. The 100% union on achieved at 12 weeks of post-operatively. So post-operative protocol, we give limb elevation, post-op X-rays, anti-DVT, and non-weight-bearing exercises. Stitch removal after 2 weeks, below knee slab for 3 weeks for soft tissue healing, and these K wires are removed after 6 weeks in outpatient department on OPD basis. Then we start stimulated weight-bearing exercises in bed to prevent the chronic regional pain syndrome. And after removal of K wires, patients were guided to follow post-operatively physiotherapy department, which included in manual mobilization of subtalar joint to prevent hindfoot stiffness. We allow partial weight bearing after 10 weeks of post-surgery, and we follow the AOFAS scoring system. So this is another case, 70 years diabetic patient. You can see this is just managed with 1 calca screw and K wire. You can see union is achieved within 12 weeks of this. So the fracture we treated is type 2 Sanders to type 4 Sanders. This is then the comparison. We have compared our study with these studies. You can see the excellent, good, and good to excellent results. The associated comorbidities are 79 patients, diabetic patients, smokers, geriatric patients, hemophilic patients. So our complication included 6% cases paresthesia or lateral aspect of the foot. In 15%, we got degenerative changes in subtalar joint, which depends mainly on the fracture geometry. And there were no cases of superficial and deep infection, skin necrosis, wound dehiscence, or implant failure, and non-union in any of our cases. So we in this study also we have maintained near normal Gisani and Bowler's angle. The advantage is this is very simple, economic. The K-wire cost actually almost 80 rupees or 50 rupees, that is less than $1. And the CC screw is also about 250 to 300 rupees. It can be utilized safely in difficult situations like open fractures, then diabetic patients, children, elderly, and mostly smokers also. And the good is the patient compliance is very good in regarding the non-weight bearing part, as the K wires are outside the skin. There are less chances of soft tissue complications, and also post-operative subsidence of the posterior facet is very less here, and it maintains axial alignment, length, and width of the calcaneus. So there are some limitations. Ours is a retrospective cohort study, no control group. We performed the standard surgical process on basis of principles of fracture fixation. Long-term biomechanical study is needed, and further follow-up is required to establish the success of this approach in attenuating long-term complications. Thank you very much.
Thank you, sir. Thank you so much for your wonderful presentation. I hope Dr. Ankit is ready with his presentation.
Hello, ma'am. Yes.
Yes.
Should I start sharing?
Yeah, start sharing. Till you start sharing, you have asked a question to Gurunath sir. Sir, how you perform simulated weight bearing with slab in situ was Dr. Ankit's question to you.
No. The weight bearing protocol is after removal of the slab.
Right, sir.
Okay. Is my screen visible?
Yes.
Okay. So, hello everyone, and good afternoon, good evening to whoever is tuned in throughout the world. And I'll be talking about use of traditional bone saws for performing bony foot and ankle procedures, which is something that we have to sort of live with when we are working in economic constraints like ours. And what we really want in our foot and ankle practice is these pen saws, micro saws, mini saws. But what we actually get is something like this, which are saws that are used for total knee replacement and hip replacement, which are larger saws with larger saw blades. But all hope is not lost, because with these saws come an array of saw blades which can be used to perform these sorts of procedures in ankle and foot, particularly osteotomies, that can be done even with saw blades that are of smaller size with large hand pieces that are usually available to us when we are working, say, locum, or when we are working freelance, when we are working in smaller operative setups, which are not really our forte or home environment, but that is what we have to make shift with, and so all hope is effectively not lost. So two common scenarios where I use such saws in foot and ankle surgery is one for KOVS correction, and the other is traditional bunion surgery that I've been doing for the last several years now. So for KOVS correction, there are a few principles that we have to really follow, which is basically to balance the muscles, keep the foot straight, respect the apex of the deformity, do a tendon transfer, which is always a must, and the hind foot should be corrected before the midfoot or the forefoot. So these are the kind of KOVS deformities that we usually get in our part of the world. And the osteotomies that we usually do, because most of them are Colvin block test positive, they are hindfoot driven varices, we have to do a calcaneal lateral slide or a lateral closing wedge Dwyer sort of an osteotomy. In addition, we also have to do a midfoot osteotomy, which is usually centered around the navicular cuneiform joint, which is usually the apex of the deformity. So these are the two procedures that we normally end up doing. One is the osteotomy that is done for the calcaneus, which is done first, apart from the tendon transfer that we usually do. And in addition to that, we do a midfoot osteotomy in the NC region. And most of these osteotomies are something that we normally do using a traditional bone saw in most of our places. In addition to the correction at the midfoot, we also do some sort of a rotation where we are getting the foot out of supination to getting a bit of pronation when we are correcting these KOVS deformities. So for the lateral calcaneal slide osteotomy, this is where the osteotomy is done. And similarly, for the midfoot, we do an osteotomy with a bone saw, but then at the same time, we have to respect the soft tissues, put a Hohmann in, use copious irrigation, and protect the neurovascular structures as well. So these are a few case examples where thus such an osteotomy has been done using a traditional bone saw. As we can see, this is a very severe KOVS deformity with a bit of equinus as well, and this is how the deformity looks like. And once we get through with the correction of the deformity, you can see that the osteotomy, which has been done here, if you can see my mouse pointer, has been done through a traditional bone saw. And this is how the fixation of the osteotomy is done. And as you can see, a TTC nail has also been done in this case to correct the deformity. And this is how the patient ends up in the end with the deformity being corrected in totality. Another case example of a midfoot osteotomy, again fixed with a midfoot plate, done with a traditional bone saw, additionally fixed with K-wires, and a lateral calcaneal slide osteotomy done with tendon transfer, which is usually a longus to brevis transfer that is done for most of these cases. So this is another case of a KOVS deformity. As you can see, the osteotomies again have been done with a tendon transfer done for the tibialis posterior, which has been drawn out to the dorsum of the foot. Another KOVS correction, you can see the deformity very severe in the top radiograph, which has been corrected using a calcaneal slide, again done with a traditional bone saw, and a osteotomy done in the midfoot at the level of NC joint, which has been corrected and fixed with midfoot plates as well as K-wires. Another case of a sort of an elderly lady who had a very severe KOVS deformity, managed with it for several years, had significant callosities and painful ulcers all over the foot, required osteotomies, which were done again using traditional bone saws. In addition to the osteotomy, she also had a tendon transfer longus to brevis, and then she also again had an osteotomy in the midfoot as well as a tendon transfer, which was done, which was because of the foot drop that she had. The tibialis posterior was transferred to the dorsum of the foot. And this is how the intraoperative views look like. And this is how the final correction was. The screw this was particularly removed later on in the course of her correction. And this is how the correction looked like at the end of 6 months of follow-up. Another case, a lady again with a KOVS, and this is how the final follow-up of hers was. Another lady with a severe KOVS. Again, the osteotomy corrections were done. The calcaneal osteotomy and the midfoot osteotomy again done using a traditional bone saw. Another case of a severe KOVS in a young male, and this is how the deformity was in the beginning. And when I got through with correcting the deformity, this is how the final picture was, indicating a significant correction of the osteotomy done with a traditional bone saw. Another case where a midfoot osteotomy was done for a post-traumatic situation of the midfoot. The midfoot was in very severe equinus, and the osteotomy again done with a traditional bone saw led to a good correction in the midfoot, as you can see on the right side. This is a very severe equinocovirus in a post-polio lady, where I did a Lamrin-Rudi procedure for her, which was again done using a traditional bone saw, and this is how the patient ended up being at the end of her follow-up period. And again, another K-virus in a young child. The fixations here were done using K-wires. Although the method of osteotomy was same, we used a bone graft in addition from the fibula, and this is how the final correction was with the lateral calcaneal slide as well as the midfoot procedure. This bone saw can also be used in PCFD cases where you have to do these sorts of osteotomies for the calcaneum, where you do a medial calcaneal slide. Again, these osteotomies have been done using traditional bone saws. Again, another MCSO case. The osteotomy here is being done using a traditional bone saw with a significant amount of slide that we can get with the 3 to 4 millimeters of width that can be taken out with these saw blades. In hallux valgus, we've been doing a procedure called promo. Promo is something that we've done over years. Although with the advent of MIS, there's been a significant paradigm shift in these procedures. And promo is something that I've really worked on quite a lot. I've done this osteotomy over the years in a lot of my patients as well. And I've had really good results with use of this osteotomy. And even with this osteotomy, I have used this traditional saw with copious irrigation. And this osteotomy gives me good results in patients, because it not only corrects the alignment in the coronal plane, but also corrects the alignment in the rotational plane as well. So another case example of a promo osteotomy, where you see in the central scagram, central clinical picture, that there is a significant rotation of the metatarsal that has been corrected using a proximal metatarsal osteotomy. Again, this osteotomy has been done not with a jig, but with intraoperative goniometers, K-wires, and fixed with a plate. And this is how the osteotomy rotation is done. And this is how the final postoperative picture is, when the nail just becomes parallel to the ground and patient has good overall correction. So these are few case examples of a promo osteotomy, all of them being done using traditional bone saws. So this is the kind of correction that you get of the metatarsal or the nail angle, where the nail basically gets parallel to the ground, and you can basically tell that there is significant correction of the rotation when you do this sort of a procedure in proximal metatarsal using a promo osteotomy. Again, a few more clinical examples of promos. This is a bilateral case in a 30-year-old female, bilateral hallux valgus, no TMT laxity, again with significant metatarsal rotation, as you can see. And this was again corrected using a promo osteotomy done for the proximal metatarsal on both the sides. Another case, and another old gentleman who had a promo osteotomy done. And so what am I really talking about? Is it really safe to use this sort of a saw in foot and ankle surgery? Because this saw is traditionally meant for knee and hip replacements. Can we use it in foot and ankle? So there are several, literature, a lot of literature that says that there is a significant amount of saw cut error. So you can see this scatter plot. This scatter plot is not of foot. This scatter plot is of TKR. And even in TKR, you can see that the amount of accuracy that is there is not really great. So is it something that really we can rely on? In addition, there is a significant risk of bone death because of the significant amount of heat that is produced when we're using this sort of a saw in our patients. And this is a comparison table that I found in literature, which showed that the tissue impact and heat generation is much more using traditional oscillating bone saws than with micro or mini oscillating bone saws. So is it really safe? So what am I really talking about? The choice of conventional bone saws is done for procedures like lateral calcaneal slide or middle calcaneal slide, for example, proximal metatarsal, as well as for the midfoot correction done at the NC joint. So these are areas which have high area of contact. There is a significant amount of bone, significant chances of union when we are talking of osteotomies done in these particular areas. In addition, there is a predictable union when that happens in these areas, and the amount of bone that is removed is something that is sort of calculated, because we want the bone to come out so as to get significant amount of correction that we want in these particular areas. So given these two factors, I have found that traditional bone saws is not something that we should be frowning upon in these areas, and given the low resources and low cost situations that we have to face, this sort of devices can be used in these particular areas. Thank you.
Thank you, Dr. Ankit. It was a wonderful presentation. Dr. Savithri is ready with her presentation.
Yes, ma'am, I'm getting it.
Yeah. Till you share your screen, Dr. Ankit, I want to ask if there are any kind of tips and tricks to avoid thermal necrosis. Do you use cold saline
Yes,
for irrigation?
I use cold saline in all my cases. I use significant soft tissue protection. I use homens on all the sides. I have an assistant who is holding the homens. There is another assistant who's like continuously irrigating the area, and then I'm using it for limited indications only. And I found that probably apart from a couple of delayed unions, I've not had any major complications, no major neurovascular injuries. Touch wood, and things have been going well. And this is turning out to be a very good low cost solution in most of my patients.
Yeah, definitely. Especially working in a government institute, we understand the problems. And do you manage the drill speed, or do you do a intermittent usage of the saw?
So I think adjusting the drill speed is something that is beyond my control. Although I use it more intermittently, especially when I'm
Yes.
going fluently, and the completion cuts are again made using traditional osteotomes. I think Rajiv Vohra sir has a comment or a question.
Uh,
Do we want to do the discussion at the end, or?
Sir, I am taking up the questions till Savithri will.
Okay.
Yeah, she's.
Is
Yeah, you
that
can. Yes, sir. If you
Good
have a
day,
question, you can
everyone.
go ahead, sir.
okay? So, this is a question to Guruna.
Yes.
In fact, most of the cases we showed was the tongue type of fractures, and sometimes you see there's a lot of combination on the body of the calcaneus, and putting those fractions into that is not possible. The transcalcaneal pins. Is there any special indication where or contraindication to those wires procedure? What we say?
Sir, we have treated Sanders type 2, 3, and most of the 4 cases also. Even in comminuted cases, what we have done is with minimal soft tissue dissection, we have maintained the height and length. With the lateral and the medial strong soft tissue support, I don't think there will be any problem. Only thing is we have to avoid impingement on the lateral side, that is most important, and avoid the varus correction, that is most important.
My concern is even if you get something on the table when the bones are very osteoporotic and there's a lot of combination, are these K wires going to hold those reductions as the time passes? And on the table you may be very satisfied you have got the reduction.
Yes, sir,
That
definitely,
the real
because
problem is the follow-up how. So according to you, all the fractures can be treated by K wires. That's what you want to convey.
yes, sir. Yes, sir. Because we have started this in government setups when we were not having the plates. But what you have seen is even in comminuted fractures, we have to keep the KYS for a long time. That is the only issue. And just maintain, just see that there will not be any varus deformity. That is the thing.
Okay. And what Ankit has shown, we have been using these, saws even at our side for indication of what he mentioned, and we never had any problems at our setup also.
Yes, sir,
So,
that's true. I think we've been universally using it. Just that it may sound a bit odd to a global audience, but although we've been using it for ages and we've rarely had any major issues with them.
I second it to you. Thank you.
Yes, sir. So we will move on to next speaker. Dr. Savithri, you can start with the slideshow.
Very good afternoon to one and all. Am I audible, ma'am?
Yes, please.
Yeah. Thank you very much, ma'am, for this opportunity. Thank you, all the seniors. After your innovative presentations, let me try sharing my humble presentation. So, this is my home ground. I work in a 2200 bedded state-run territory center in the central part of the capital city in Hyderabad, where there is a footfall of nearly 400 to 600 orthopedic patients on an average day, with more than 95% from low-income group. And the foot and ankle patients, they comprise at least around 5% of the lot. So in the place where I'm staying, it's like giving a vegetarian and non-vegetarian buffet. So I had
Dr. Savithri, are you going to the next slide? We can't see your slide move.
Oh, yes, ma'am. I have gone.
Yeah, yeah. Then you will have to do the same way of going to the next slide as we saw in the previous session. Click on the slide on the left side.
Is it visible, ma'am?
No, 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 no. It is not visible. Come out of the slideshow.
Okay, ma'am.
Come out of the slideshow.
Yes.
Which can you click on the left side? There will be.
Yes, ma'am. Yes.
Yeah, you can go ahead with this. Yeah, that's better. You can
Okay,
have
ma'am.
to click on every slide for your presentation. Yeah, go ahead.
Okay, okay, ma'am.
Lot
Yeah.
of back, noise.
Yes, sir.
From my side, sir.
Yeah, yeah, you can go ahead, Dr. Savithri. Yeah.
Right. So I work in a area which to 2200 bedded state-run hospital with 95% of low income group and a footfall of 400 to 600 orthopedic patients, of which 5% are the foot and ankle patients. So I work in an area where it's like it's a state run hospital, so it supplies all the implants and I have to choose from the implants which are already available there. I will not have the pleasure to order the implants of my choice. It's like a vegetarian being taken to a non-vegetarian buffet, lavish non-vegetarian buffet. So these are the challenges which I face. The limited access to healthcare. Sorry for the animation not being played. Financial constraints of the patients, cultural and linguistic barriers, limited health literacy, poor hygiene and untreated comorbidities, delayed presentation. They present to us usually very late, after 2 or 3 months, sometimes even after 6 months to 1 year, when they start developing arthritis. The other addressable barrier or the accessibility gap, where we have inadequate infrastructure. This is the OPD where I work, where many number of patients are there and we have inadequate infrastructure, untrained and unchecked handling, especially in the rural areas where they are treated by quacks, geographical limitations, the fear and mistrust which the people have to come to a city center and get it treated, rather they would get it treated by a quack in their own place, and the competing priorities. They all obviously choose to treat or get other needs fulfilled than getting a foot problem treated. So, the way I tackle the limited resources along with my other colleagues is alternative implants. Example, using shorter supracondylar nail for TTC fusion, re-sterilized implants, which we use usually for the external fixators, and after validated sterilization and achieving per proper autoclave, we use them. And using alternative immobilization, we don't go for expensive walking boots. We use light, locally made PVC orthotics. And minimal hardware fixation, where using K wires and Steeman pins and external pins instead of using the internal fixation plates and all. This is a simple uh, fracture with peritalar dislocation with navicular fracture, which we have tried to reduce with K wires and Herbert screws and screws which are available. We don't have plates. So locally assembled post-op care kits. We have basic foot elevation pits. I don't advise people to go to uh, fancy prosthetic people. I advise them to go to a local cobbler where they can do all the available fits which can be trained, who is available just right outside my hospital. So these are the innovative things which I have done in the past 1.5 to 2 years using the supracondylar nail. This is a patient with above knee amputation on the left side because of Charcot's, obviously. On the right side, he had this varus ankle. So I had to use a supracondylar nail to fix it. I didn't have a TTC nail, and obviously only screw fixation is not advisable. This is an endo button with the washer which I've used as a syndesmotic tightrope in a patient with old chronic syndesmotic tear with medial malleolus non-union. Here are the K-wires are used instead of screws and plates in minor fractures where TBW, where we don't have the fancy plates for the Jones. And most of the cases, what we are doing here is uh, in cases of chronic TA tear and insertional Achilles tendinitis, we are going for endoscopic FHL transfer with a normal anchors and interference screws so that patient will have early mobilization, early return to work, which is the major demand of all the low income patients. We are usually making them walk if there is no tear and if there is only partial tear and just insertional Achilles tendinitis with more than 50% degeneration. We are able to achieve return to work in less than 3 weeks. And especially when it comes to complex trauma, where we have gruesome cases referred from other centers after a lot of time. We are planning to go for an orthoplastic approach, getting it right the first time so that we reduce the comorbidity, we will reduce the tissue management and optimize the functional outcome of the patient and the hospital stay and make them return to work early. This is the post-operative protocol I usually follow. I follow a tailored protocol considering patient genuine concerns. I listen to them, ask them what their general concern is, which prevents them from coming to me for follow-up. So I try to attain or achieve to that first. Patient and family education before discharge, especially the attenders. Clear illustrated post-op instructions in the local language. Demonstration of wound care and signs of infection. And most of the times I try to go with minimal incisions, and if they need thorough debridement and uh, dressings, I ask them to go for normal saline dressings. Suture removal, I encourage them to get at their nearby PHCs instead of coming back to the city again. Dressing protocol is basic saline dressings with local materials, whatever is available with them. Physiotherapy is home-based exercises. I usually I demonstrate every exercise which has to be done at home. And this is the patient of bilateral Lisfranc who has visited me after complete open bilateral open Lisfranc. He has visited to me after the dressing suture removal after at least 2 months of surgery. So follow up also, I ask them to come at least after 2 months or 3 months, whenever it is feasible, depending on the case. 85 to 90% follow up compliance achieved up to 6 months, reduced rates of infection, implant failure, and fewer readmissions. Coming to few cases, this is a post-traumatic case with it's a 7 years post-traumatic case. A patient who is walking on a valgus angle with the loss of medial arch and continuous weeping areas on the medial side. So her she was prepared to get amputated elsewhere. She wanted to go for below knee amputation elsewhere. So later she came and visited us. Then we have told her there is an option of fusion, but she wanted her only because she underwent dressings, many dressings previously for the trauma, which you're able to see clearly. Her only thing was, I want minimal dressings. So these are her CTs where we can see it is completely in valgus, the ankle and the subtalar joint, which is unstable. These were the medial malleolus screws which are left. So we have opted for an arthroscopic procedure for her, where I know in coronal plane deformity, regular posterolateral and posteromedial portals are not advisable. So we have opted for posterolateral sinus tarsi portals and the leap subtalar arthrodesis leap portals, which have proven to be effective in especially in coronal plane deformities. This is the, and we have done a Chopot's amputation with lateral plantar perforator artery angiosome as the wedge. We have completely closed. And this is the patient who is walking. As I've told, this footwear is made from the local cobbler who is present right in front of my hospital. So it is very cost effective for the patient. So the key outcomes are union rates. We have achieved union rates in over 90% of fractures using low cost alternatives. This is a syndesmotic tightrope using that endo button and the washer which I've used. The patient happy with the movement with all decked up leg. And functionality, 85% patients regained acceptable functional mobility, majority returned to daily activities within 3 to 6 months. And obviously, this reduces the follow-up cost, 70% savings due to fewer hospital visits. And home-based wound care, saving approximately 8,000 to 10,000 per case using the modified approaches, local implants. The other key thing which is very important is the communication with the patient. As you all know, they need a lot of assurance and satisfaction and trust. So I make sure that I explain them everything. I make sure I have my juniors who are well versed in the protocol, where everybody, even if the patient asks somebody else also, they'll be able to tell what we are up to. And the other thing what we are usually doing is a telemedicine thing. So patient feedback and social impact especially will help us reduce the complication rates. So, based on my experience, the potential solutions and the effective steps towards equities, policy advocacy, community health initiatives, financial assistance programs, health education and literacy programs, making the people aware that such facilities available and such care is possible, especially in our places. With limited resources, also it is available. We are able to achieve good functionality, telehealth and remote monitoring, training for healthcare providers, and collaboration, especially with other departments and our healthcare providers also. So, equality and equity, equality is giving everyone a shoe, but equity is giving everyone a shoe that fits. Hope everyone has a happy feet. Thank you.
Yeah. Thank you, Dr. Savithri. Now we can take up questions for a few minutes. Uh,
Are there any questions from the audience or not, or should we?
there are no questions from audience, sir. If
So,
time permits, I can show a few slides. Even I have few cases of mine.
sure. Very good.
Go ahead, please.
Yeah, we are
Okay,
waiting.
sir. Yes, sir. Yeah.
You still have another
8 minutes
8
time, sir. Yeah.
minutes to go.
I hope my screen is visible, sir.
Yeah, yeah.
Yes.
Okay. Yeah. Okay. So already Dr. Savithri has spoken so much about why there is delay and in how do I tackle is being tertiary care center. We do have post-acute exams and we admit the patients who do not have any health scheme card and admit them in bulk so that their admission and surgical procedure become free of cost. This is one of the way how I overcome the treatment barriers in low income group. And this gentleman, 49-year-old male, with small business, he came very late because he couldn't come because he was the only person who was earning money, and he had a mid substance tendo Achilles tear. There were no bystanders when he came to me. Now these are intra-op clinical images, 6.5 centimeter loss, and again he was a poor patient, did not have much money. So what I did, I planned for a long FHL transfer. This is the harvesting of the long FHL by minimal invasive method, and taking out of the wound and drilling a tunnel into the calcaneum and suturing it back. This took me only 1 or 2 vicryl to suture it, and the cost was only 4,000 rupees, which comes lesser than a $50. And I had to put him on a cast for around 3 months. And I usually buy valve and retain the cast because he can use it intermittently rather than having a expensive AFO. So this is how I overcome the financial barriers in few patients. He came to me after 6 months, and he is walking well. His plantar flexion is really good, as we can see on the video. Yeah, he's walking really well. Another patient, 23-year-old, with meningomyelocele. She had a sequelae of right foot intervention, and she was walking on tibia. She couldn't come to any hospital because she did not have money. When she started earning money, she came to us for disability assessment, and we planned for salvage for this lady, and we can see she is walking on tibia on bilateral side. So again, we do not have very fancy implants available in our institute. So we planned for one foot at a time so that she can use the other foot for going back to work. I used just distal end radius plates for fixing this foot. I did the tibia to midfoot fusion with the recon plate and a distal end radius plate. And now at 2 years follow-up, she is really walking well. Even the opposite foot has been treated. These were the clinical images when she came to us after implant removal on the other side. Another case of non-healing ulcer where the ulcer was there for 4 years. And in this case, we did a MIS, multiple metatarsal floating osteotomy, multiple because I did not wanted the patient to come again for admission, and did a gastroc recession in this case. This really healed well in 6 weeks. We can see, and the patient came walking to me after 6 weeks. Another case of Charcot's arthropathy where I have used plates, but unfortunately the plate got exposed, and patient had atherosclerotic changes, so no flap was done. I did a transverse tibial distraction. This device costed me very, very less amount because I used only 2 K wires and a shank spin, and the other devices I usually reuse in with my Ilizaro set. So the cost was only around 100 rupees in this lady, and this procedure has given me very good result, and this is the end result where the ulcer healed well and she came walking after 6 months follow up. So these are the few cases which I wanted to show where we can do procedures with very, very limited resources also in a government setup like where I am working. So if there are any questions, we can take up.
There is a question in the chat box that is there any low cost option to do Akin or Chevron osteotomy without availability of micro saw? Anyone who would want to take it?
So although not recommended, I have done a short scarf and a transverse Akin using traditional, using a small saw blade, but with a traditional bone saw. But although this is definitely something that I would not recommend, I think the person who's asked the question, Dr. Sudeep, we've already answered the question that a seri is definitely a very good option. If you're short of resources, you can just go for a transverse osteotomy, fix it with a wire. I think that's a great way to go. Although it can be done. The other osteotomies that you mentioned can be done with a traditional bone saw, but use a smaller saw blade. Be very, very careful. It is better to use it at more forgiving places rather than trying to do a scarf with a traditional bone saw. Definitely not recommended, but can be tried, of course.
There's one question. Can I ask?
Yes, sir. Yes, sir.
We've been saying the use of the implants again. Yes, we have been using the fixators, not the shank spins, but the connecting rods and
Yes, sir.
with that. But using an implant again, which has already, lost its strength, it is not what you see over there. So how far we can go and advocate using an implant which has spent its energies and undergone all types of wear which promotes infection. Maybe we can get a low-cost implant, but reuse of implant for internal fixation, I don't have much of experience. If any of the panelists have, I would like to know.
Sir, I don't think so. Internal fixation implants can be reused,
That
sir.
was comment by the Savithri, or so that is probably I brought it out
Yeah.
to advocate it or not.
Yes, sir. It was actually it was published in some studies that they can be implants can be reused, especially internal fixation implants. But in my personal experience, I haven't used any implant as such. Sir. I've used the connecting rods and the external fixator rings which are there. That's it.
I think we are on time, sir, to finish the session.
Thank you very much. Dr. Aradhna Rathod and team.
Thank you, sir.
You are spot on. You finish your session well in time.